47, Neurological System Function Assessment and Therapeutic Measures. This will be the live lecture that will be posted on Canvas. You need to know all of your vocabulary words and the words in the bold and italicized lettering. The nervous system has two divisions: the central nervous system, which consists of the brain and the spinal cord, and the peripheral nervous system, which includes the nerves of the autonomic nervous system. Actions are either automatic by reflex or result in gathering, organizing, and processing data. There are several different types of neurons. A neuron is a sensory neuron, afferent, a motor neuron, efferent, and an interneuron between the afferent and the efferent neurons. Receptors are specialized to detect internal or external changes and then generate the electrical impulses. Sensory neurons are from receptors in the skin, skeletal muscles, and joints. They are called somatic. Sensory neurons from receptors in the internal organs are called visceral sensory neurons. Motor neurons are in nervate skeletal muscle called somatic. Motor neurons that innervate smooth muscle, cardiac muscle, and glands are called visceral. And if you'll look there in the little learning tip box, there on your actual chapter or page 981, there's a good little learning tip there for you to be able to figure out if it's afferent or efferent, and I definitely would make sure you know that. Under nerve impulses, know what action potential is, which is an electrical change brought about by the movement of ions across the neuron cell membrane, and the refractory period is the time after being stimulated when a nerve cannot react to another stimulus. Know what a synapse is, which is an electrical impulse that's incapable of crossing the actual synapse. Know what spinal cord reflexes are. So when you have a stretch reflex, a muscle that is stretched automatically contracts. The common one, the example they give you in your book, is your patellar reflex. So all skeletal muscles have a reflex. If a patellar reflex is absent, the problem might be with the quadriceps femoris muscle, the femoral nerve, or the spinal cord itself. If you have the reflex present, then that means everything is working the way that it should be. The brain has four principal areas. We have the cerebrum, the encephalon, which is the thalamus and the hypothalamus, the brainstem, which is the midbrain, pons and medulla oblongata, and the cerebellum. Make sure you know these four principal parts, and then what is the different parts of that as well. On page 984, look at figure 47.6. That gives you a breakdown of all the different parts of the actual brain, so make sure that you know that as well. There's 12 cranial nerves in the brainstem, and on the table 47.1, make sure you know what each of those numbers are, know the name and the function of the cranial nerves. So that's on page 985, and that table goes over to 986. On page 988, the learning tip there, it talks about the sympathetic and the parasympathetic. Remember, the sympathetic is when our fight or flight response kicks in. So therefore, we get an increased rate of our heart. Our heart starts racing, and the force of our heart contraction is increased. Our bronchioles dilate to get more oxygen into our muscles. We have decreased digestion, which that means we have decreased peristalsis. So our digestion slows down so we don't waste energy. And then our bladder relaxes, and when it relaxes, we have decreased urine output, so we don't have to go to the bathroom. Parasympathetic is when the body is brought back into balance and rest. It's when our body is just going back to normal. On page 989 is figure 47.10 is the aging in the neurologic system. With the aging, it is normal to get decreased blood flow to the brain, which can increase syncopal episodes and decrease mental function. Also, we can have an impairment in our cognition or reasoning, judgment, or orientation. We also can have an altered sleep pattern because we have a decrease in norepinephrine. We can have an impaired short-term memory where we just kind of are not necessarily remembering all those short-term details. A decrease in dopamine, which decreases our motor function, which makes them more accident prone and fall risk. When you are doing a neurological assessment, we need to determine the history of the neurologic problems, assess the level of consciousness, obtain vital signs, specifically the blood pressure, pulse, and respirations, check pupillary response to the light, assess strength and equality of hand grip and movement to the extremities, determine the ability to sense the sense of touch or pain in our extremities. When we're actually doing a physical exam, we want to go in and meet our patient, but we also want to inspect and palpate and percuss with the neurological system. So when we're percussing, we're actually using the reflex hammer. We're using that to actually be able to check the reflexes in the arms and the legs. Equipment that you're going to need to do that physical exam is clean gloves, a reflex hammer, and like a sharp pointed object. One of the exams we're going to be looking at or assessing is going to be our level of consciousness. A fully conscious patient is going to respond to questions automatically. As the consciousness is impaired, the patient may show irritability, they may have a shortened attention span, or an inability to cooperate. If they have any of those, we consider that a negative change. And also, if they're falling asleep in mid-sentence, that's considered a negative change in level of consciousness, and we need to report that to their healthcare provider. Level of consciousness is the first thing that we want to assess when we're doing that neurological assessment, because that information that we obtain during that assessment may cause us to modify the remainder of the exam if necessary. Things that we may collect while we're checking the level of consciousness. Obviously, we're going to be looking at the mental status. Disorientation is often an initial sign of neurological disorder. We're also going to be looking at intellectual function. We're going to be asking patients to maybe like count by sevens or count by fives for a certain amount of time. If you interrupt this patient while they're doing that, they may have a delay in problem solving to pick up where they left off. That's not really an unusual thing, because if you or I were to be interrupted, we'd have to think about it to be able to pick up where we left off. The thought content, we want to look at and assess if the patient has the ability to interpret the information, and we want to make sure that they can act appropriately as well, and that's an important safety issue and activities of daily living. We're going to look at the perception. So you might show a patient a pen and pencil and ask them what each one is. Agnosia is the inability to interpret or recognize familiar objects, and we may see that in like a stroke patient or somebody that has brain lesions. Their language ability, you're going to have them read the following sentence. So you give them a sentence to read, and so we want them to be able to read that. If they're not able to, a lot of times it's because they may have a different type of aphasia, and it could be because they've had an injury to different parts of the brain. And memory, we may ask the patient to repeat 4 or 5 words and have them repeat it again in 5 minutes. So we're looking to see if they have impaired memory. And if they do, it may be because of delirium, dementia, or it could be related to a stroke. We're going to check their pain level. So you're going to ask them again on a scale 0 to 10, with 0 being no pain, 10 the worst ever pain. What's their level of pain? Pain perception can be altered by different spinal injuries, medications, alcohol, stress, or a level of consciousness. You know, you may have some spinal injuries and the patient may say they don't have any pain whatsoever. But those are all things that we want to collect related to their mental status. Another test that we typically look at is the Glasgow Coma Scale, which is the GCS. It's an international scale that we use to assess level of consciousness and document findings. We use it to evaluate patients who have a potential for rapid deterioration in consciousness. And so their motor response is scored on the Glasgow Coma Scale based on commands, responding to pain, and displaying abnormal postures. Abnormal postures include decoordinate or decelerant. Decoordinate is, or flexion it's called, is posturing. The patient's arms are flexed at the elbow, the hands are raised toward the chest, and the legs are extended. This posture indicates significant impairment of cerebral functioning. And there's a picture of that over on page 991 in the figure 47.11 if you want to look at the actual different posturing, the ways that the posture would demonstrate either one of these. In decelerant or extension, posturing, both the arms and the legs are extended, the arms are internally rotated. Both of these are abnormal posturing, and they both indicate damage in the area. If it is decoordinate, it's impairment of cerebral function. If it's decelerant, it's damage in the area of the brain stem. Depending on which one they do is depending on which part of the area of the brain is actually injured. The total possible score for the Glasgow Coma Scale ranges from 3 to 15. A score of less than 7 indicates a comatose patient, and a score of 15 indicates the patient is fully alert and oriented. When you total up the scores, a score of 13 to 14 indicates a mild head injury, 9 to 12 indicates moderate injury, and a score of less than 8 or below, indicates a severe head injury. If you do the Glasgow Coma Scale and then you start seeing deterioration in the patient's condition, which means they have a lowering of the Glasgow Coma score, you have to report that to the healthcare provider immediately. Another score that we use is called the 4-score scale. It stands for Full Outline of Unresponsiveness Score Coma Scale. It's a newer tool that has been introduced into critical care and emergency department areas. The 4-score scale uses 4 categories. It uses eye response, motor movement, reflexes, and breathing pattern. And then the maximum of 4 points can be earned in each of those areas. In general, the lower the 4-score scale is, the worse the patient is neurologically, and the poorer the prognosis. Controversially, the higher the score, the better the prognosis will be. We're also going to look at the mental status. Mental status can be affected not only by the aging process, but many neurological disorders and injuries. One of the common ones that we see is the traumatic brain injury, because it can result in memory impairment, delayed amnesia, affective mood disorders, and dementia. And so there's several ways that we can actually assess that. One of them is the confusion assessment method, which is called CAM. Another one is called the mini mental state exam. The mini mental state exam is an assessment tool that tests orientation, registration, attention and calculation, recall, and language. And your book gives you kind of a little example of some of this as well. CAM, which is the confusion assessment method, we use to diagnose delirium. And then they look at acute onset and fluctuating course, the inattention, the disorganized thinking, and the altered level of consciousness. And so any change in mental status is something we should be taking seriously, even if a patient takes a lot of medications, because the primary cause of delirium and acute states of confusion is adverse effects from medications. There's a lot of other causes as well, but when we are looking and thinking about the actual mental status changes, it's something that we need to be able to recognize quickly and report as well. When you assess cognitive function, you are evaluating the patient's thinking capacity. You want to determine the length of attention span, the ability to concentrate, judgment, memory, orientation, perception, problem-solving ability, and motor function. I'm not going to talk a lot about the examination of the eyes in this lecture, but I do want you to make sure that you know all the words that are in bold, and I also want you to know all the words that are in the italicized writing. We've already discussed some of that or all of that actually, in the chapter when we did sensory. And then we examined the muscle function. And so we use a 5-point scale to document muscle strength. So we want to ask the patient, to push against, put our hands out, have them push against us. We may have their feet out, have them push against the feet. If to test the deltoid muscle, we ask the patient to raise their arms above their shoulders, push down with their upper arms. We test hand grips or grasp. We do the arm drifts. We have them put both their arms out and see if one drips lower than the other one. Muscle leg muscle strength, we have them push against our raise their leg, flex at the hip, push against us with their feet as well. The Baginski's reflex is tested by firmly stroking the sole of the foot. A normal response is flexion of the great toe. So when you stroke the bottom of the foot, your big toe should kind of go up. If that big toe extends and the other toes actually fan out, then obviously we expect a neurological dysfunction. When you have a baby less than 6 months old, they're gonna have that actual reflex. But after 6 months of age, they should start, that reflex should go away. Then we have the Romberg test. It's performed by having the patient stand with their feet together, their eyes closed. A negative Romberg test means that the patient experiences minimal swaying for up to 20 seconds. A patient who sways or leans to one side is said to have a positive Romberg test, which may be seen in cerebral dysfunction. If you look on page 995, table 47.5, it tells us how we would actually collect information on cranial nerve function. So just make sure that you read over that and kind of familiarize yourself with that. When we're looking at lab tests, as far as what lab tests we do for the neurological system, there's not really any specific diagnostic tests that we actually do. But depending on our history and physical, then we may decide, the healthcare professional may decide to look at specific labs for underlying causes of symptoms. They may look at some thyroid hormone levels. They look at the B12, a CBC. They may look at the creatine kinase. Then they also may look for, STDs. Sexually transmitted diseases, and if they were looking for sexually transmitted diseases, they would do the VDRL, which is your venereal disease research lab test for syphilis. They may check a liver function, a renal function test, erythrocyte sedimentation rate, and a white blood cell count. And really, we're looking at all of those to see if we have any kind of infection going on. So we would look at that. The anticholinergic testing and antibody titers are useful for diagnosis myasthenia gravis. So that's a specific test that we may do for myasthenia gravis. Other tests may be a lumbar puncture, an X-ray exam, A CT scan sometimes is used to look at neurological disorders of the brain and the spine. If a CT is done with contrast, we have to check kidney function because that contrast is actually metabolized through the kidneys, and you don't want to give it to somebody that already has some kidney function issues. And those tests would be your BUN and creatinine levels. Also, too, we really want to question this patient about allergies. If this patient has an allergy to dye, any kind of dye, especially contrast dye, shellfish or iodine, we obviously would not want to give this to them, or we would give them medications prior to giving this to contraindicate or to help with the allergy reaction. Also, too, patients that are receiving dye should be warned they may feel a sensation of warmth following the injection. That warmth is in the growing area, and it might make them feel like they've been incontinent of urine. So we want to tell them, make sure that, if they feel this warmth, that it's not that they've peed on themselves. Nausea, diaphoresis, itching, and difficulty breathing can indicate an allergy to the dye. We should report that immediately if this patient has any of those feelings. And you want to make sure you tell your patient to tell you if they start feeling any of these things. Some patients that are agitated or disoriented has to be sedated in order to have this test. And patients who are in pain should be medicated with pain medication before the exam. So because they're having to lay still on a movable table, we want this patient to be as comfortable as possible. So make sure that if they have pain that they are medicated prior to the exam. An MRI is another test that is done to check for different degenerative diseases. And we've talked before about the MRI. You can just kind of read that area and get yourself familiar with it. A myelogram is another test that is done. It's an X-ray exam of the spinal canal and its contents after they inject contrast material. Once again, they're injecting a contrast material, so we want to find out about their kidney function, ask them about those allergies, and tell them if they start feeling any of the nausea, the diaphoresis, itching, or difficulty breathing, to let you know. Some reasons that we may do a myelogram is to check to see if they have any kind of compression, nerve roots, herniation of intervertebral disc, or blocking of the cerebral spinal fluid circulation. We also do the myelograms for anybody that has severe pain in their lower back that's aggravated by movement, because that will give us, with this actual x-ray exam, it gives us a good look at what's going on in that spinal canal and its contents. All right, other therapeutic measures that we may be doing. Whenever we have a patient and we're moving and positioning this patient, we really want to make sure that when we're actually moving or putting them in a different position, that we're taking care to make sure that their body is in a good body alignment. We also want to keep all the body parts in functional positions. So like you want to keep the trunk in a position where if they can kind of move, that they are able to. You want to keep their hands and their feet to where they can use them or move them if they need to. If they have some contractures, we want to splint their hands to keep their thumb and their fingers opposed. If they've got contractures in their feet, we may use high-top tennis shoes, but to keep those feet in appropriate position for standing and walking. When we are repositioning a patient, we want to make sure that we keep the patient's call light within reach. We want to make sure that that new position that we've put them in is comfortable. We do not want to massage reddened or blanched areas that may be on their back, but we want to make sure we keep that pressure off of those bony prominences. We want to make sure that no body part is compressed. So we want to, if they're laying on their side, you want to make sure that their arm is not tucked up underneath them, that it's able to be positioned in a way that it's not compressed against their body. Same thing with breast. Activities of daily living can be affected if the patient has any deficits, like if they're unable to lift their arms above their shoulders. Obviously, there's going to be some of their activities of daily living that they have problems with. So they may have trouble brushing their own hair, maybe washing their hair, those sort of things. So ADLs can be affected depending on what neurological disorders that they may have. As far as communication goes, a patient, if they have difficulty speaking because of a neurological disorder is dysarthria, and patients that have dysarthria know what they want to say but cannot be understood, and they can become they can't be understood is what I meant to say. They can become very frustrated, and we commonly see that in stroke patients. Expressive aphasia is difficulty or inability to verbally communicate with others. Once again, this can be very frustrating for the patient as well. For individuals with no intelligible speech or with word finding difficult, a picture board is commonly used to facilitate communication. One patient that I took care of one time had a stroke at one of the facilities, and she honestly had you couldn't understand anything the woman said, but when she was in her wheelchair or any time she tried to talk to you, she would say, "Kumati, Kumati, Kumati, Kumati," and we're like, what is she trying to tell us? But that's how she actually talked to everyone. You'd ask her a question, "Kumati, Kumati, Kumati" is how she would answer you. And so, honestly, we couldn't understand what that meant. So we would have to show her pictures or point to objects to be able to communicate with her, because she could shake her head yes and she could shake her head no. So I think she understood a lot, even though we couldn't understand what she was saying. And you could use one simple one word, like you say, like, do you need to go to the restroom or go to the bathroom? Expressive aphasia affects the patient's ability to understand spoken language. So with expressive aphasia, the patient may have more trouble understanding like what you're telling them. So they may only understand very simple directions like sit down, squeeze my fingers, wash your face. I mean, very specific, very small, short, very simple directions. When you have a patient with receptive aphasia, assume that he or she cannot understand or follow safety instructions. So, like if you say, "Don't stand up until I get back," they're probably not going to understand you. So you need to just, kind of say, "Don't stand up." And then you have to make sure that when you are leaving that patient that you're really making sure that somebody's there with them in case they were to fall. So we want to just be very careful with that patient, especially safety-wise. Nutrition, alterations in level of consciousness can really cause a patient's not going to recognize if they're hungry or thirsty. It might impair their ability to be able to safely swallow. They may have severe weakness. All these conditions compounded together are going to may increase the metabolic rate that accompanies their neurological injury or illness. If you have even a question about the patient swallowing, you want to make sure that you get that evaluated by the speech therapist. They will do a swallowing evaluation. If your patient has a swallowing difficulty, which is dysphagia, we may have better access with foods or thick liquids rather than thin liquids. So we may have to actually thicken their liquids. Just remember, you can't do this without a physician's order. All patients should be positioned as upright as possible while eating and drinking. Patients who have difficulty swallowing should be monitored during eating and not left alone, obviously for safety reasons. Serving small portions of food more frequently can increase their intake. Using high protein, high calorie foods and supplements increases the nutritional content for small amounts of food. Obviously, if they can't swallow the food or chew, or they can't swallow, or they can't swallow enough food, then we would have to do the tube fittings. And a lot of times, this can be, if it's short term, we can do an NG tube. If it's going to be more, we realize it's going to be a long term thing, obviously, then we'd want an actual G tube or J tube. As far as family goes, when we have a patient with neurological deficit, a lot of times these patients aren't able to be cared for at home, so they have to go to a long-term care facility, or if they're at home, then the family has to provide all that care and rehab. So really depending on the diagnosis, that patient's family really is going to need a lot of support from not only just the staff, but they may need support from an outside area as well. If you've got a patient with Alzheimer's disease, their family, may need to join an Alzheimer's support group. Education is going to be very vital importance, especially if this patient's going home. We want to make sure that we give this family as much education in how to take care of that patient the best way that we can. That concludes the actual lecture. Just to make sure that you read the textbook, read chapter 47, and I will be posting on Facebook the study guide. Actually, it's already posted. You actually have to click on the external tool when you click on chapter 47 study guide. You'll pull it up, you'll click on it, and then you'll kind of scroll down and you'll click on, I think it says iCloud external tool. You click on that. It's actually a Google document, and you'll be able to type directly onto that study guide. And then once you have completed that study guide, then you need to submit the assignment. So you're going to submit the assignment, then I'll be able to look at it and give you a grade.